Hi, my name is Alicia, and this is my protocol presentation for you on ulcerative colitis. The definition begins with understanding that the classification of inflammatory bowel disease contains both Crohn's disease and ulcerative colitis. The main difference between the two is that in Crohn's disease there is inflammation and ulceration of any part of the digestive tract, whereas in ulcerative colitis it is confined to the colon, and in 95% of patients it has rectal involvement. The etiology of ulcerative colitis is unfortunately unknown, although it is accepted that there is an abnormal immune response in the body that causes the inflammation. It is most likely triggered by an infection or toxin that the body is unable to take care of. It causes a cascade of inflammation that is resolved only if there's scarring of the area, or it will continue until there's an intervention, and the inflammation and ulceration will become more severe. The incidence of ulcerative colitis is 5 to 12 cases, and the prevalence is 70 to 150 cases, each per 100,000 patients per year. So it's pretty common. It is found predominantly in the developed areas, which has kind of sparked a lot of research into what the difference is in developed areas compared to the more undeveloped countries. However, when looking at the literature, you don't want to exclude any patients from Asian background, because even in the Asian countries, the incidence of ulcerative colitis and Crohn's disease is increasing. Your screening and risk factors: a family history is a big one. Your patients that have a family history of inflammatory bowel disease are up to 10 times more likely to develop a disease themselves. And depending on the progression and the location of the disease in the family member, your patient is most likely to follow the same course. Being Jewish and a former smoker both increase your risk, and being a current smoker and having an appendectomy are both protective against development of ulcerative colitis. The incidence varies dependent on the source that you use as far as age is concerned, but pretty much your teenage years up until 30 or 40, you have an increased risk, as well as you age, mainly in your 70s, but also you can have it in your 5th and 6th decade as well. As far as your clinical findings, it somewhat depends on the severity of the disease. With your history, the patient might complain of rectal pain, fatigue, nausea, seeing blood or mucus in their stool, diarrhea, sometimes some fecal incontinence, rectal urgency, and abdominal pain. The more common symptoms would be the rectal pain and bloody diarrhea. For a physical exam, if the patient is in more of a mild disease or is in remission, you will not have any symptoms. However, if the disease progresses, the patient can present with tachycardia, abdominal pain, weight loss, and fever. In your differential diagnosis, you'd include infectious and ischemic colitis, diverticulitis, hemorrhoids, lactose intolerance, irritable bowel syndrome, antibiotic-induced diarrhea, and Crohn's disease. These symptoms of bloody diarrhea and abdominal pain are pretty vague and can be caused by any of these diagnoses. Specifically, with your antibiotic-induced diarrhea, you want to get a good history and examine what medications they've been on recently. And don't forget, when you have a patient who has ulcerative colitis, they can also have a coexisting infectious cause of their symptoms when they present to you. For social and environmental considerations, there's the hygiene hypothesis to think of. This states that because of the widespread use of antibacterial soaps and hand sanitizers, you're limiting a lot of the contact with organisms that children would have growing up. So when they are in a position where they encounter infectious bacteria and such in the future, their body is and their immune system is unable to fight it adequately, and that results in your altered immune response that's thought to be the cause of ulcerative colitis. Something to note is that this hypothesis is backed up when they went and found that those living on farms who are exposed to a lot more and those that were drinking non-pasteurized milk had a very much lower incidence of ulcerative colitis as compared to those living in more industrialized areas and cities and such. Your diagnostic testing for ulcerative colitis. In your lab work, you'll find anemia if they've been having significant blood loss, electrolyte imbalances, elevated liver function tests, leukocytosis, and elevated ESR and CRP. Your ASCA and your PANCA antibodies, they can diagnose inflammatory bowel disease, but it doesn't specify whether you have Crohn's disease or ulcerative colitis. They can be helpful, however, because if you have a positive PANCA and a positive ASCA, you have more of a prevalence for Crohn's disease compared to ulcerative colitis. You would definitely want to test the stool for blood culture and sensitivity, ova and parasites, and C. diff. You're going to rule out all of the infectious causes. And radiology, something to note is if the patient is going to have a colectomy, an MRI should be done to exclude small bowel disease. This would preclude having a colectomy and suggest more of Crohn's disease. You can also use CT to show inflammation in various parts of the intestines and go towards an infectious cause as well. Ultrasound can be helpful. More research needs to be done to determine how you can use this. It can measure the depth of the inflammation and the location so you can get an adequate view of what's going on without the radiation exposure as you have with CTs and X-rays rather. Your sigmoidoscopy can diagnose ulcerative colitis by visualizing the colon and taking biopsies. Complications of ulcerative colitis. The most severe are the toxic megacolon, bowel perforation, peritonitis, and hemorrhage. The things that you want to look out for would be the non-intestinal manifestations that are listed there. They pretty much hit many of the body systems. And specifically, you need to refer to the specialist if needed, specifically if they have ocular manifestations. Treatment of the disease depends on the degree. If you have toxic symptoms, you most often need to be admitted to the hospital. Pharmacological management consists of 3 main medication classifications. This includes the 5 ASA, corticosteroids, and immunomodulators. All of these can be used for flares and for maintenance treatment. However, the corticosteroids are primarily used for severe flares to keep the patient under control and get them into remission. Some patients end up being dependent on the corticosteroids. And also in children, it can contribute to a slowing of their growth. Your non-pharmacological methods. Surgery is curative. A colectomy will cure the patient from ulcerative colitis. There are a couple of different surgeries in this department that includes the proctocolectomy and endoleostomy, or the restorative proctocolectomy, which is an IPAA. That one is more popular because it can still maintain the flow of the stool appropriately without having to have an ileostomy. However, the patient will never experience normal bowel movements. That's something that they should understand prior to going through surgery. There's another surgery that's called incontinent ileostomy, and that has a higher complication rate, so it is not used as much now. And diet has not shown to be significant for improving ulcerative colitis. However, you should understand what the patient feels about their diet and what they're avoiding, because they can end up having deficiencies in their nutrient intake. Counseling and education. The nutritional intake medications, their risk of infection is huge because oftentimes they're immunocompromised, and keeping track of their immunizations is important as well. It is imperative that you prevent them from acquiring any disease that can be prevented by immunizations, but do not give them a live vaccine since they are often immunocompromised. Referrals can be varied depending on if they have any extraintestinal manifestations that need to be managed by a specialist. However, the gastroenterologist is number one. They typically will diagnose the patient and start their therapy. Nutritionists and support groups can be helpful for these patients because ulcerative colitis is a very difficult diagnosis to deal with. A psychiatrist or counselor can also be helpful in that regards. And the ophthalmologist there is listed as one of the referrals for the ocular manifestations. Follow-up is very important in these patients. They need to be regularly monitored for their medications to adjust them if needed and identify if they're having any adverse reactions or if the therapy is effective. And that is it. I hope you've enjoyed my presentation.